Welcome, listeners. This is the Deep Dive, your shortcut to mastering complex subjects by really getting into the most vital, needle-moving insights from the source material.
And today we are taking a really close look at aesthetic perfection. We're going way beyond just lining up teeth straight.
Yeah, we're diving deep into the architecture, you could say, of the ideal smile. Thinking about harmony, the math behind it almost,
Yeah.
and then placing that detail within the bigger picture of the whole face.
That's right. We're focusing on the microscopic details, but anchoring it in the macro landscape.
Exactly. So our mission today, it's to really break down what makes a smile look great, aesthetically speaking. We're zooming in on the smile arc.
A fundamental concept.
Totally. And we'll establish those crucial horizontal reference lines you need for symmetry. We'll look at the tiny details, like the vertical relationship between the cutting edges, something called the incisal step.
Very important, that step.
And then, maybe the most surprising part, we're going to look at some really interesting research about how universal some facial features might be, even across, 6 different racial groups?
Yes, quite a diverse study. It challenges some common assumptions.
It's all about finding that harmony, isn't it? From like the stability of the line between your eyes down to the tiniest millimeter difference between your front teeth.
It really is a journey from that big facial scaffolding right down to the nitty-gritty aesthetic details. So where should we start? Maybe with the absolute cornerstone.
Yeah, let's define that consonant smile arc first. Okay, the smile arc. This really is ground zero for dental aesthetics, right? Doesn't matter if you're in ortho, prosto, or just aiming for beautiful cosmetic work. If you don't get this right, the result just won't look, well, good. People might call it the incisal arc sometimes.
That's another term for it, yes. But the core idea, the principle, it stays the same.
And the definition itself, it sounds pretty precise.
It needs to be, especially when we're talking about aesthetic goals. So the smile arc describes the relationship in space between two things. First, the cutting edges, the incisal edges of the upper front teeth.
So centrals, laterals, canines.
Exactly, that whole front group.
Yeah.
And second, the curve that the upper edge of the lower lip makes when someone gives a certain type of smile.
Okay, and you mentioned consonant earlier. A consonant smile arc. What makes it consonant? What's that harmony look like?
Parallelism. That's the key. For it to look right, aesthetically harmonious.
Yeah, harmonious.
The curve of those top teeth, the cutting edges, that curve has to perfectly mirror, run parallel to the curve of the lower lip when they smile. They need to follow the same path, geometrically speaking.
So if the lip curves up gently, the teeth edges have to curve up gently right along with it.
Precisely. In perfect sync.
And it's important to know when we're looking for this, right? It's not during a huge belly laugh.
No, definitely not. That kind of full-on laugh involves different muscles, different positions. Clinically, we evaluate this during what's often called the social smile, or sometimes a postural smile. It's that more polite, controlled kind of expression.
Like you'd use in conversation or for photos.
Exactly. During that specific smile, the lower lip forms a really distinct, quite stable curve, and the upper incisal curve, it has to track that line perfectly.
What happens if it doesn't? If the teeth line is flatter?
It instantly looks off, heavy, maybe older. It just doesn't have that dynamic, youthful look.
And the fact that most people naturally have this, that's why it's such a strong aesthetic standard, isn't it?
It really is. The data is compelling. Studies show that the vast majority, we're talking around 85% of people, naturally have this parallel consonant relationship.
Wow, 85%.
Yeah. Without any dental work, their upper incisal curve matches their lower lip curve. That high prevalence tells us this is what our eyes, our visual system, are basically programmed to see as natural, as harmonious, as youthful.
So conversely, if that line of teeth is just straight across, flat,
it's generally considered unaesthetic, or even, the literature might call it ugly.
harsh.
Well, it's blunt. An appealing result, a successful aesthetic outcome, it has to have that curve. If the treatment just creates a flat, straight line, it just lacks life, that dynamism.
And you mentioned age. Does a flat line make someone look older?
It absolutely can. Think about natural aging. What often happens, the edges of the teeth wear down.
Right, from use over time.
Exactly. And that wear tends to flatten the incisal plane. So a flat incisal line visually signals age, signals attrition. The curve, though, that's the aesthetic standard that suggests vitality, good form.
Yeah.
That's why getting that parallelism is just non-negotiable for success.
So if 85% of people have it naturally and everyone prefers the curve, It really highlights that as clinicians, we need to actively design that curve back in, not just hope it happens when we straighten teeth.
That's a great way to put it. It's an active design element. We're often correcting against things like wear, maybe even slightly flawed development, to get that dominant, beautiful curve back.
Okay, so we need that beautiful curve. But a curve can still look wrong if the whole thing is tilted right.
Absolutely. The foundation has to be level.
You can have the perfect curve relative to the lower lip, but if that entire unit is skewed horizontally, the whole smile looks off, immediately flawed. So before we get obsessed with the curve itself, we need to nail down the horizontal plane. Where do we find that solid, unchanging reference point on the face?
This is the anchor. You absolutely cannot assess symmetry or alignment properly without a baseline that doesn't move, regardless of, say, muscle pull.
Okay.
Now, you could look at a few things on the face. The line between the eyebrows, the bottom of the nose, the corners of the mouth.
Yeah, those seem like candidates.
But they all have issues with stability. Soft tissue movement, muscle action. They can all shift. There's really only one line that gives us the stability we need.
And that is?
The interpupillary line. Simply the line connecting the centers of the two pupils.
The pupils. Why are the eyes so much more reliable than, say, the corners of the mouth when someone smiles?
Think about what happens when you smile, even that social smile. The corners of your mouth get pulled up, right? Your cheeks might bunch up a bit. The base of your nose might even change shape slightly.
True. Lots of movement in the lower face.
Exactly. But the pupils, they're anchored in the skull. That interpupillary line represents the most stable horizontal structure we have. It's our best bet for a true horizontal reference for the whole face.
Like the horizon line in a photograph.
Yeah.
It needs to be straight for the picture to look right.
That's a perfect analogy. The interpupillary line is the face's horizon.
Okay, that makes sense. Stability is key. But then there's biology. Faces aren't perfectly symmetrical, are they?
Far from it, and that's the challenge. While we use the interpupillary line as our stable reference, we have to accept that natural asymmetry is actually the norm. It's not the exception.
So people might have one eyebrow a tiny bit higher, or ears at slightly different levels?
Exactly. Even the bone underneath, like the orbital rims, might have slight variations. This natural difference means we have to kind of ignore those other less stable landmarks and really stick religiously to that interpupillary line as our gold standard for establishing what's level.
All right, so we use the pupils as our horizontal guide. Now, how do the teeth normally relate to that line? In the general population, are the incisal edges usually perfectly parallel to the interpupillary line?
Well, this is where it gets really interesting. The answer is no, not always.
Oh.
While our goal as clinicians is usually to achieve that parallelism for the best aesthetic outcome, studies show that in a pretty significant chunk of the population, maybe around 30%, the natural incisal line isn't parallel to the pupil line. It has a slight cant, a tilt.
30%. That's almost 1 in 3 people. That's huge.
It is.
So if that many people naturally have a slight tilt, what does that mean for the clinician? Do you always correct it? What if the patient has lived with it forever and never noticed?
That is the million-dollar question, clinically speaking. Often, that natural tilt comes from deeper issues, maybe slight skeletal asymmetries, which we'll touch on later.
Okay.
But the clinical implication, it generally remains the same. Even if a slight tilt is natural for that individual, a visual tilt in the smile is often flagged by an observer's eye as, well, not quite right. Asymmetry catches the eye.
So the perceived aesthetic is key.
Exactly. Therefore, the practitioner really must use the interpupillary line as the primary, non-negotiable standard for orienting that cutting-edge line, the incisal line of the upper teeth. If we don't get that horizontal plane level first, any beautiful curve we create will just be sitting on a crooked foundation.
So job number 1 is fixing any horizontal tilt relative to the eyes.
It has to be. You establish the level plane first. Even if the patient's nose is slightly asymmetric or their mouth corners aren't perfectly even, you align the teeth to the pupils. You trust the eyes as the most aesthetically reliable horizontal anchor.
Got it. Align the teeth to the most stable universal reference point first. Prerequisite established. Okay, so horizontal baseline set check. Level with the pupils. Now we zoom in. This is where that smile arc, that beautiful curve, really starts to take shape at the millimeter level. And this brings us to thinking about the incisal edges themselves, something you called incisal age.
Yes, Incisal age is a useful term. It refers to the appearance and condition of those cutting edges. Do they look sharp and unworn, which you often see in younger people, or are they flattened, maybe chipped, suggesting more age or wear?
Right.
So analyzing the incisal edge position is critical. We need to look at the inclination, that's the subtle forward or backward tilt of the front teeth.
Okay.
And we have to measure really precisely the vertical relationship. How close are those edges to the lower lip when the lip is at rest? Is there contact? Or is there a gap? And if so, exactly how many millimeters?
That level of detail matters. But you said earlier, the secret to the curve itself, that graceful aesthetic arc, isn't just about how long the teeth are overall. It's about the difference in length between the front teeth. The incisal step.
The incisal step, absolutely. This is the feature that makes the difference between a flat, boring line and a dynamic, pleasing curve. It's simply the vertical height difference between the central incisors, the front two teeth, and the lateral incisors right next to them.
So if you picture soldiers lined up, all exactly the same height, that's the flat, unaesthetic smile line.
Good analogy.
You're saying for a great smile, we need a little step down, like a tiny staircase effect.
Precisely that, a staircase effect. The central incisors need to have what we call aesthetic dominance. They should be the longest, the most prominent teeth visually in that front segment. The lateral incisors, the ones next door, they need to be positioned slightly higher up or just be slightly shorter, creating that vertical step-off. That difference is what allows the overall curve to follow the lower lip gracefully. If the centrals and laterals are exactly the same length, the incisal line has to be flat, period. No curve possible.
Okay, so how much of a step are we talking about? Is there an ideal measurement, a Goldilocks zone?
It does vary a bit, patient to patient, based on their features and the desired look. But generally, the clinical sweet spot seems to be somewhere between 0.5 millimeter and 1 millimeter.
So not a huge difference, but definitely noticeable.
Exactly. Getting that specific vertical difference right is crucial. If the step is too small, say less than 0.5 millimeter, you risk it looking flat again, kind of aged.
And if it's too big?
If it's too dramatic, maybe 2 millimeters or more, it can start to look unnatural, maybe like the teeth are chipped, or gives that awkward sort of picket fence appearance.
Right, where the size difference is jarring.
Yeah, the perfect step creates this illusion of flow, of continuity, even though there's a height difference.
And aesthetically, what does having those slightly shorter lateral incisors actually do for the smile's appearance?
It does a couple of key things. It creates important negative space visually, and it adds interest.
How so?
Well, the shorter laterals allow more light to hit and reflect off those dominant central incisors, making them stand out, drawing the eye naturally to the midline. That difference also introduces a little bit of shadow and depth, which softens the transition as you move back towards the canines. It often makes the smile appear a bit more delicate, maybe more feminine, and definitely more youthful.
Whereas if the laterals were the same lengths as the centrals.
The whole smile can look kind of heavy, blocky, less refined.
Now, this isn't just about looks, is it? We have to connect this micro-level precision back to how the teeth actually work.
Oh, absolutely. Function is always linked. The exact position of those incisal edges is critical because it directly impacts phonetics.
Speech scenes.
Yes. Specifically, how a patient makes sounds like F, V, and even S. Think about it. When you make an F or V sound, your upper incisal edges lightly touch the wet-dry line on the inner part of your lower lip.
Right, I can feel that. If, V, V, V.
Exactly. If the teeth are restored slightly too long, the patient might develop a bit of a lisp or notice clicking sounds when they speak. If the teeth are too short, they might actually struggle to make clearer F and V sounds because they can't get that proper contact.
So getting that incisal step right isn't just for looks, it's crucial for clear speech too. Aesthetics and function hand in hand.
Fundamentally integrated. The perfect step ensures both things work optimally, the appearance and the articulation.
Okay, we've laid out the ideal. Parallel curves, horizontal symmetry based on the eyes, and that crucial little incisal step. But obviously we see smiles where this isn't happening. A disharmonious smile arc, maybe it's flat, maybe it's even inverted or just really tilted. That tells us something went wrong or something needs fixing.
And the first step is figuring out why. Diagnosis is everything here.
Right. You need to know the cause before you can treat it.
Exactly. When you see a non-consonant smile, you need to differentiate the cause. Generally, we can group the origins into two main buckets. Clinical causes, things that are, let's say, man-made errors.
Okay. Treatment-related issues.
Yes. versus anatomical or skeletal causes, issues that are inherent to the patient's own structure.
Let's start with the clinical ones, the failures that might happen during or after treatment.
The main culprits here often come from orthodontics or prosthodontics. Let's talk ortho first. There's critical work by, well, many renowned aesthetic orthodontists. You sometimes see them referenced by initials like S, who really hammered home the importance of correct bracket placement, specifically the vertical positioning of the bracket on the tooth crown.
Okay, vertical bracket position. How can putting a bracket just a little too high or too low on the tooth mess up the whole smile arc?
Well, the bracket is where the arch wire sits. It's the handle you use to move the tooth. If the practitioner may be aiming for speed or just misjudging the tooth's long axis or center point, places that bracket even slightly off the ideal vertical spot. The orthodontic mechanics, the wire trying to level everything out, can inadvertently pull the cutting edges into alignment. It forces them into a straight line.
So in trying to get the brackets lined up, it actually flattens the incisal edges.
Precisely. The system aims for a straight wire, and in doing so, it can completely eliminate that necessary vertical step between the central and lateral incisors. You end up with teeth that are perfectly straight according to the wire, but the smile line itself is flat. Aesthetically, it's a failure, even if it's mechanically correct.
Wow, so the very act of straightening can flatten the curve if you're not meticulous about that bracket height.
It's a classic error, and correcting it. It often means taking the braces off, repositioning those brackets correctly, and then maybe using special finishing wires with bends in them to actively reintroduce that vertical step and rebuild the curve.
Okay, so that's ortho. What about prosthodontics? Crowns, veneers.
Similar potential for error. If a patient gets restorations, crowns, veneers, maybe a bridge, and the lab or the dentist doesn't make the cutting edges correctly, particularly if they make the central incisors too short.
They lose that dominance you mentioned.
Exactly. They lack dominance. The result is automatically a flatter, less curved appearance. You lose the parallelism with the lips simply because the teeth aren't shaped right.
And then there's this stuff patients do themselves, habits that can wreck even perfect treatment over time.
Right. Attrition. Wear and tear. This comes from grinding, clenching bruxism, or maybe just having a bad bite, a malocclusion, that puts extra force on those front teeth. Over time, that force literally grinds down the incisal edges. They get shorter, they get flatter, they become level with each other, and poof, there goes your essential vertical step, and the curve disappears with it.
So the patient basically grinds away the aesthetics.
They do. And the really critical point here for the clinician is if you just restore those worn teeth, aesthetically make them look nice again, but you don't address the reason they wore down in the first place, like the grinding habit or the bad bite.
It'll just happen again.
It'll just happen again. The aesthetic fix will fail because the underlying functional problem wasn't solved.
Okay, those are the clinical or acquired causes. Now let's talk about the deeper issues, the anatomical or skeletal causes, the ones baked into the bone structure.
These are definitely tougher nuts to crack, generally speaking, because you're dealing with the foundation itself. A classic example is skeletal asymmetry.
Uneven bone structure.
Yes. For instance, you might have unequal lengths in the vertical parts of the lower jaw, the mandibular rami, sometimes referred to as RUS ramal, unequal size or symmetry.
Okay.
If one side of that supporting lower jawbone is significantly shorter or longer than the other, the entire platform that the lower teeth sit on can be tilted, which means the upper teeth meeting them might also be tilted or compensate in some way.
So if the actual jawbone is tipped, the teeth sitting on it are going to look tipped too, even if the teeth themselves are perfectly straight relative to each other.
That's the issue. And you probably can't fix that kind of tilt just by moving the teeth around with braces.
Right, it's a skeletal problem, not just a tooth problem.
Exactly. And detecting it can be tricky sometimes. From a straight-on frontal view, the soft tissues, the cheeks, the lips can sometimes camouflage minor underlying bone discrepancies.
So you might miss it if you don't look carefully.
You might. To really diagnose it properly, a clinician often needs to use cheek retractors to pull the soft tissues back and get a clear look at the underlying bone landmarks. For instance, comparing the heights of the maxillary tuberosities.
The bony bumps behind the upper back molars.
That's them. If one tuberosity is noticeably higher or lower than the other when you look straight on,
what does that tell you?
it's a strong indicator that the entire maxilla, the upper jawbone itself, is tilted or canted. The whole foundation is uneven.
And if the upper jaw foundation is tilted?
Then, trying to make the teeth perfectly level with the interpupillary line might make them look weirdly related to their own bony base, or vice versa. You have conflicting reference frames. Correcting that level of asymmetry often requires more than just braces. It might involve orthognathic surgery to reposition the jaws, or maybe very complex restorative work, perhaps using implants placed strategically to compensate for the bone discrepancy.
So the bottom line is, figure out the root cause.
Mm.
Are you fixing crooked teeth, or are you dealing with a crooked skeleton?
That's the fundamental diagnostic question.
We spent a lot of time on the micro stuff, that incisal step, the curve, lining up at the pupils. But all these tiny details live within the bigger framework of the whole face.
Macro view.
Which brings us to this really fascinating area of research, the quest to see if there are universal aesthetic standards for faces that apply across different populations globally.
Yeah, this was the idea behind a really significant study, a multi-center interracial investigation. The researchers wanted to move beyond subjective ideas about, say, Caucasian aesthetics versus Asian aesthetics or African aesthetics, and see if they could objectively measure extrural features, the parts of the face around the smile, and find common norms.
Features that frame the smile.
Exactly, stable features. They wanted to know if, deep down, the human face follows a common blueprint, aesthetically speaking.
That's a pretty big goal. Who did they study? What was the scope?
It was quite comprehensive. They looked at 253 people, aged 18 to 41, say, mature adults with stable facial structures. And crucially, they included participants from 6 different racial groups: African American, Caucasian, Chinese, Hispanic, Japanese, and Korean.
Wow, that's a broad range.
Very broad. And they used standardized methods, strict protocols, to measure 7 specific frontal features and 6 profile features. Things like distances, angles, proportions. This ensured they were comparing apples to apples across all the different groups and research centers.
Okay, standardization is key for that kind of comparison. Let's get to the findings. What about differences between men and women? Because this result really jumped out at me.
It's quite striking. Statistically, the researchers found no significant differences between the men and women in their study group for any of the 7 frontal measurements or the 6 profile measurements they took.
Wait, hang on. 0 significant differences across all 13 external facial measurements between men and women in this diverse group.
That's what the data showed for the parameters they measured.
That's genuinely surprising. Clinically, we often talk about making a face look more masculine or feminine through treatment, but this suggests the basic underlying dimensions of the facial framework might be incredibly similar.
It implies that, at least for these specific measurements related to overall facial height, width, the relationship between major features, the fundamental skeletal dimensions might be remarkably consistent. Obviously, there are secondary characteristics, skin, hair, maybe brow bone prominence, that differ, but the core structural parameters defining proportion and symmetry, they appeared universally consistent between the sexes in this study.
Okay, mine's slightly blown on that one. Now, what about the comparison across the 6 racial groups? This seems like the main thrust of the study. Did they find distinct aesthetic profiles for each group?
This is where it gets potentially revolutionary for aesthetic thinking. The study found no significant differences between those 6 distinct racial groups. For the majority of the frontal measurements specifically, 5 out of the 7 frontal parameters they looked at, and also for 1 of the 6 profile parameters.
5 out of 7 frontal parameters showed no significant difference across African American, Caucasian, Chinese, Hispanic, Japanese, and Korean groups. Can you give examples? What kind of measurements are we talking about that seem to be universal across these diverse populations?
We're likely talking about things related to the basic structural scaffolding, measurements like maybe overall facial height, the distance between the inner corners of the eyes, the intercampal distance, perhaps the width across the cheekbones, the bizygomatic width. The core elements that the interpupillary line and the smile arc are built upon seem to follow fundamentally consistent proportions.
So despite obvious visible differences in skin tone, hair texture, maybe even specific tooth shapes, the underlying mathematical proportions that define the canvas of the face, especially from the front, seem to hold true as norms across these groups.
That is the profound implication of this research. While we absolutely acknowledge and appreciate that specific dental aesthetics, things like enamel shade, the exact shape of an incisor, maybe soft tissue thickness, can and do vary ethnically. Right. The foundational external dimensions, the measurements that frame the smile, seem to adhere much more closely to universal measurable standards than previously thought.
This gives a pretty strong mandate to the clinician then, doesn't it?
Yeah.
It reinforces why using something stable like the interpupillary line is so important, because that line is likely operating within a framework of these universal macroaesthetics.
Exactly. The The study concluded that most frontal facial parameters, and at least one profile one, could potentially serve as reliable norms for patients pretty much everywhere, regardless of their sex or ethnic background.
So it gives you a clear, objective starting point for treatment planning.
It does. It suggests that while we must always personalize treatment and honor the individual's unique features, the basic structural framework we're working within likely follows a universal blueprint. This data gives us more confidence to treat the face based on fundamental geometric principles of harmony and proportion, without worrying quite so much that we might be violating some specific, deeply ingrained ethnic structural norm for those measured parameters.
It sort of flips the planning hierarchy, maybe.
Yeah.
You ensure the fundamental framework aligns with these potentially universal structural norms. First level with the pupils, good proportions. And then you fine-tune the microaesthetics, the two sides, the shade, the exact curve of the smile arc, the initial step to honor the patient's individual look and background.
That's the balance, exactly. The macroaesthetics, anchored by stable references like the pupils, provide that universal foundation. The microaesthetics deliver the crucial individual personalization. #outro.
Wow. Okay. This deep dive really took us on quite the journey. We started way out with the macro view, these potentially universal facial norms.
The big picture.
Then zoomed right down to that critical horizontal anchor, the interpupillary line. And then went even finer, analyzing the millimeter-level goal of the consonant smile arc and that tiny but vital incisal step.
And we connected the dots, how those dental elements, the curve's parallelism, that vertical step, have to harmonize perfectly with both the moving parts like the lower lip curve and the fixed references like the pupil line.
Right. And we also touched on what happens when it goes wrong. Diagnosing whether it's a clinical error, like maybe poor bracket placement causing flatness, or a deep skeletal issue like uneven jaw growth or tilted foundations.
Understanding the why behind the disharmony.
Exactly. So here's where it gets really interesting, and this is kind of our final thought for you, the listener, to chew on. If this research is pointing towards many frontal facial features following potentially universal norms across races, how does a clinician strike that perfect balance?
A balancing act.
Yeah. How do you pursue those universal rules, that objective geometry for harmony, while simultaneously respecting and celebrating the subtle, beautiful variations that make each individual's face unique, their specific ethnic features, their family resemblance? Where does the universal aesthetic standard end? And where does that essential, unique personalization begin?
That really is the ultimate tension, isn't it, between the science and the art in aesthetic dentistry and orthodontics.
Something to think about. Thank you so much for joining us for this deep dive.
It's been a pleasure. Until next time.
Bye-bye. 1 second pause.